Evaluating a case of tuberculous lymphadenitis. Tuberculous lymphadenitis is a common form of extrapulmonary tuberculosis. Cervical adenopathy is most common, but inguinal, axillary, mesenteric, mediastinal, and intramammary involvement may also be present. It is more frequent in females and in the younger age groups. Clinical presentation. Tuberculous lymphadenitis may present as a unilateral single or multiple painless lump, mostly located in the posterior cervical or supraclavicular region. When a patient presents with lymph node enlargement, inquire about the onset and duration. Patients usually present with rapid onset of nodal enlargement, followed by a gradual increase in nodal size over 2 to 3 weeks. Measure the size of the enlarged node. Most nodes remain less than 3 centimeters in diameter. The skin overlying the node typically develops a pink to lilac red hue and becomes thin and parchment-like. Fistula formation can be seen. In HIV-positive patients, the lymphadenopathies are more commonly seen as symmetrical and multiple, contrasted with presentation with focal and asymmetrical lymphadenopathies of HIV-negative patients. Gross features of caseating tuberculous lymphadenitis are firm, matted, nodes with yellowish, central caseation on the cut section. Tuberculous lymphadenitis can occur in 2 types. In type 1, there is caseation, matting due to periadenitis, cold abscess, and sinus formation. Here, body resistance is less, and drugs may not reach effective concentration into the area of caseation, and so resistance and residual disease is common to develop. In type 2, firm, non-tender, discrete node is seen without central caseation. Cold abscess and sinus will not occur. Host resistance is good, and so shows good and rapid response to drugs. Disease passes through 5 stages. The first stage is the stage of infection and lymphadenitis. In stage 2, there is periadenitis and matting. Stage 3 is the stage of caseating necrosis and cold abscess formation. In stage 4, there is collar stud abscess formation, where caseating material passes through deep fascia into subcutaneous tissue and gets adherent to the skin. The last stage is the stage of sinus formation. Physical examination reveals the presence as firm swelling, which is not warm, non-tender, matted, usually mobile, and can be adherent to adjacent muscles. Cold abscess is soft, non-tender, smooth, fluctuant, non-transilluminating, well-localized, often non-mobile swelling, with free non-adherent skin over the surface. Skin will be adherent at the collar stud abscess stage. Investigations. Possible diagnostic steps include positive tuberculin test, chest radiograph, CT scan, cytology or biopsy, AFB staining, and mycobacterial culture. The treatment of choice for lymphadenitis caused by Mycobacterium tuberculosis is multi-agent, anti-tuberculous antibiotic therapy for 12 to 18 months. Nodal regression typically occurs within 3 months. Because of the effectiveness of anti-tuberculous agents, the surgical excision of draining nodes and sinuses is infrequently required. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.